Dear panelists, ladies and gentlemen, my PhD takes a translational approach to the prevention of diabetes after acute pancreatitis. I'm Olga Zahariev, a UK-trained dietitian working at the Center for Pancreatic Diseases at Semmelweis University. My vision is a world where preventable diabetes is prevented, and my mission is to shift health policy towards prevention and to educate patients. I have two projects. The first project aims to identify patients at risk of developing diabetes after acute pancreatitis. Until recently, it was believed that acute pancreatitis causes only a temporal imbalance in health. However, 3 out of 5 patients develop diabetes or prediabetes within 5 years of their acute pancreatitis episode. Diabetes has a huge health and economic burden on society. Moreover, compared to type 2 diabetes, post-pancreatitis diabetes has a worse prognosis, such as higher all-cause mortality, higher cancer-related death, worse glycemic control, despite earlier insulin therapy commencement as well. There is a gap in knowledge. Approximately 3% of post-acute pancreatitis diabetes cases are diagnosed correctly. Therefore, as a first step, my project aims to identify patients at risk of developing diabetes after acute pancreatitis. Patients with acute pancreatitis without diabetes at the point of discharge compared various biomarkers to their absence, such as severity, necrosis, and obesity. We believed that diabetes develops significantly more frequently after acute pancreatitis that was severe, necrotic, or caused by hypertriglyceridemia. The search has been carried out and identified nearly 12,600 records, of which 45 studies could be included in the analysis. The combination of risk factors and outcome pairs was 71. And to briefly summarize the data, I will show you aggregated forest plots showing the pooled odds ratio for each risk factor and outcome pairs. An odds ratio over 1 indicates that there is a higher odds of developing the event in the exposed group. The exposed group is always going to be in the first column. And the outcome, the event, is either denoted as diabetes or prediabetes/diabetes mellitus, which is a composite outcome due to the fact that some of the studies did not differentiate and combine together the cases of prediabetes and diabetes mellitus as well. So on this first figure, you see the association between severity and the development of dysglycemia. You may notice that having severe or moderately severe disease progression is associated with increased odds of developing dysglycemia. And it was also more pronounced for prediabetes and diabetes compared to diabetes alone. Figure 2 shows the association between etiology, the local complications, necrosis, and cirrhosis formation are associated with an increased odds. And there was a tendency for recurrent pancreatitis increasing the dysglycemia. However, it did not reach statistical significance, which we explore in the discussion part. Figure 3, where we studied the etiology and the association with dysglycemia, we found that hypertriglyceridemia is associated with there's a tendency for increased odds of developing dysglycemia. It again did not reach statistical significance, but it's probably because of the small number of studies, and systematic analysis part found also that having hyperlipidemia at disease onset was significantly associated with post-pancreatitis diabetes mellitus. So that's probably just a small sample size. Alcoholic pancreatitis, though, was significantly associated with an increased odds, and the complementary parts, biliary and idiopathic etiologies, were associated with significantly lower odds of dysglycemia. And we also explored a couple of other comorbidities and demographic factors. However, we found no statistical significance for these. Largely, you notice that they were including only 3 studies, and one of them accounted for 50% of the data, which was a high-risk bias study from the US, only 1 year long. So this is actually the first comprehensive meta-analysis of using within direct study comparisons, using robust study methodology, and we had some large pooled sample sizes. However, the research was limited by the fact that the included studies often used different methods and time points for defining and assessing the outcome. Also, a third of the analysis pulled data from less than 4 studies. So all in all, I could say that having severe, moderately severe disease, local complications, and alcoholic pancreatitis is associated with significantly higher risk of developing dysglycemia. There's a tendency with some of the factors, and we have also found that biliary and idiopathic etiology is associated with a lower risk of prediabetes and diabetes mellitus. So while every patient would benefit from checking and monitoring their dysglycemia status following acute pancreatitis, at least the high-risk group should be followed up closely. Policymakers, we encourage them to acknowledge that long-term complications exist and to make recommendations in the guidelines, because so far it has been only mentioned in the Chinese guideline in 2021, and that's not enough. Researchers are encouraged to develop strategies for preventing diabetes following acute pancreatitis. There are no studies as of yet within this area. Also, appropriate follow-up schedules would benefit those who are making the guidelines. So the first submission to GOT when I prepared these slides was rejected. We have submitted the American Journal of Gastroenterology, and we are waiting to hear back from them at the moment. I also presented my data at 4 conferences and traveling this week to the EPC again. The effect of dietary fat content is my second. There's an interventional study I'm involved in, which is the EFFORT study, investigating the effect of dietary fat reduction on the recurrence of pancreatitis and endocrine insufficiency as well. We know that acute pancreatitis patients, a significant proportion of them goes on to develop recurrent episodes, and 10% of them goes on to develop chronic pancreatitis. To prevent the recurrences, there are some strategies for alcoholic pancreatitis, such as abstinence, and in biliary cases, it's the removal of the gallbladder. However, all patients are advised to keep a low-fat diet as a lifetime sentence without actual evidence behind it. Therefore, my study aims to test dietary fat reduction's effect on acute pancreatitis recurrence in a randomized controlled trial setting. So we are exploring patients with diabetes, with acute pancreatitis episode, 2 or more of them within the last 2 years. And the intervention arm is dietary intervention, one of them including 15% of fat content of total energy expenditure, and the other one is 30% fat content. The primary outcomes are acute pancreatitis recurrence and all-cause mortality. We believe that dietary fat restriction reduces acute pancreatitis recurrences, mortality, and long-term complications. The study design, so as I mentioned, we are looking to recruit patients who had 2 or more episodes of pancreatitis, and the number, the sample size calculation told us that we need approximately 400 patients in both of these arms. We would exclude patients who are malnourished because they require different dietary advice. The study is actually 2-year-long dietary intervention, and we are also following them up for 2 years. During this time, we meet with them 6 times, collect data at each time point, and also they are able to see the dietitian. This was the request of the patients to have more frequent visits. As I mentioned, the primary outcomes are recurrence of acute pancreatitis, all-cause mortality, but we also explore various secondary outcomes, such as specific mortalities, newly diagnosed chronic pancreatitis, serum lipids, fat-soluble vitamins to check the safety of a low-fat diet, and the endocrine functioning is also assessed. We also do body composition analysis to see if it changes during the time, and dietary adherence is monitored as well. So the clinical trial progress is presented here. We have the ethical approval 2 times already because we have submitted a modification. It's also registered, and we have enrolled already some patients, but it's also a continuous really working on the protocol to making it better and better at the center where we have started it. So it's still in pretty much lots of work. The patient, when they are with us, they spend their whole morning with us because we do laboratory testing, the body composition, they see the dietitian, they see a physician, and we have to do the ultrasound testing as well. So it's quite a long day with us. We have developed the dietary intervention as well. As I'm the dietitian who was put in charge of the project, I was overseeing this part. We have weekly meal plans as well, and all kind of guidelines and lists to help the patients to adhere to it. As I mentioned, we have already started enrolling patients. We have started last year in May, and we only recruited 8 patients. That's because it's a very restrictive inclusion criteria, so we are actually just discussing whether we need to modify the inclusion-exclusion criteria, whether it needs to be altered, because you will see that the projected end time for it, well, it's going to be finishing in 2034, the interim analysis, and then it's 2046 for the final results based on the current speed that we are progressing at. Thank you for your attention. If there are any questions, I'd be happy to answer them.
Excellent presentation, Olga. Thank you. The first study, I think a single episode of pancreatitis, certainly in children, is mostly caused by an infectious cause, and nothing happens afterwards. So why are you so convinced that there is going to be damage causing possible diabetes after one attack of pancreatitis? You did mention in the other factors if it's recurrent. If it occurs again, I agree with you 100%. But after one attack, what evidence do you have?
Well, there was actually a study from, I think it was from DAS, where they have only included patients with with only one acute pancreatitis episode, and that's where they found that the 3 out of 5 patients do develop it. So even just one acute pancreatitis episode increases the chances of developing diabetes. There are several possible mechanisms behind it. One of the common ones is that there is some cellular loss in the pancreas when it gets damaged, but it's also believed that it could be the systematic and or local inflammation could alter the protein transcription, and there could be triggering autoimmune processes, and that could be the reason with the similarity that they need with the type 1 diabetes, the similarity that they need earlier insulin therapy commencement. So that is also a possibility, but we don't actually know the proper pathomechanism behind it as of yet.
Nice work. Both studies are in adults, I guess.
Yes, both of them are in adults.
Okay. For the second study, you mentioned that you will assess vitamin K.
Yes.
Which way?
Well, we are doing the biobank samples at the moment, and it was told to me by the head of the unit that we will send them at the very end to be checked for that. We are checking the vitamin D even for each time point, but that's the only one that we could ask from the national health system to be checked immediately. The biobank samples will be analyzed at the very end.
How many patients do you want to have at the end? Because to show a difference with this intervention, I think you would need at least about 100 or...
Well, yes, so the sample size is 190 for both arms. So that's quite a lot, but the sample size calculation will also have to be a little bit maybe reassessed, because they based it, there's no data previously for this kind of intervention in acute pancreatitis patients. Therefore, it was based on a study that was like intervention for alcoholic pancreatitis patients, which was abstinence, and they checked the efficacy of those. So it's not quite a dietary intervention, and it's not quite appropriate. So maybe what we could do is do a pilot season, and then from those data determine what would be the appropriate sample size.
Interim analysis which shows
Definitely we want from that to recalculate, but it's still going to be 2034 for the interim analysis.
Thank you for your presentation. You just highlighted in your project these groups who are at risk for dysglycemia after acute pancreatitis, and have you already implemented your results in clinical practice? So what dietary intervention is needed in these groups, or of course abstinence? I think it's obligatory, how to say. So as a dietitian, what do you recommend, or how is this done?
So I'm lucky enough that I'm working at the specific center which is dealing with pancreatitis patients, and we have a psychologist as well on the ward. So they are supporting our work from the alcoholic abstinence part, but also even adhering to a low-fat diet. They are also supporting that part, because they told me that patients were like calling them up like, oh my God, but what will they think about me on the countryside if I start to eat like people at Budapest? Like, how can that be? And so he just told me about it afterwards. And I was like, thank you so much for helping me out, because that's the psychological part of it. We also do for alcoholic patients, we do a smaller range for the low-fat diet, because there is no current evidence to suggest that they need the low fat for a long time, but we emphasize for them the alcohol abstinence. For those who have been biliary, it's low fat for sure. And even after the gallstone removal or gallbladder removal, we tell them that they slowly could increase the amount, because at the moment that's what's recommended.
So thank you for your presentation. It was excellent. I'm just wondering, what type of screening would you advise after pancreatitis? So it will be an OGTT, or will be fasting glucose measurements will be enough or sufficient, or just a random glucose sampling, because there are so much options.
Well, once you have the episode, you need to wait kind of 3 months, because there is stress hyperglycemia potentially in those periods. So the official time is to test it after the 3 months are up. I would recommend to do all three, because from other areas of research we see that they overlap but not completely. So doing fasting and the OGTT and the HbA1c, I would advise for all of them. But there is actually requirement. I would say that potential research is needed in this area to determine what's the best parameter to see in the future.
So, and what do you think that these high-risk patients for this glycemia, do they need more closer follow-up after pancreatitis than the other etiologies, or?
I would say so, yes. That's what we believe. They will need more frequent, but we don't have the time. We can't advise on the time, because that's not what we were aiming at.
That would be my other question, that what time do you recommend for them?
I would say probably within 6 months the first test, and then 1 year, and then every half or 1 year or so. There is a significant increase within the first year in the prevalence, and then also from 5 years they see an increase. But as it has been discussed, and even yesterday there was a lecture, the pancreas might have a capacity to regenerate. So even people who develop prediabetes or diabetes might then maybe recover and go back to normal glycemia status. So continuous monitoring is what I would go for.
Congratulations to your presentation. During this long time period, do you give any recommendations or restrictions for the patients about exercise?
Well, we used to have physiotherapists on the ward, but they both quit. So we just encourage them if they can, because we also see sarcopenic patients. Oftentimes alcoholic pancreatitis patients are malnourished, and they need to be, often for them the advice is eat more. You need to eat more and focus on workouts as well. So we do advise in the absence of a physiotherapist as well.
Yes, in your meta-analysis, you used aggregated forest plots, so we could not see the individual study result. So my question is that in this case, what information is given for us to assess the heterogeneity?
I provided the I-square, and that's what I presented in these slides. The publication in the supplementary material, we could fit in the individual forest plots, but in this case it was only the I-square statistical test that I could show you, which we could, to explore the heterogeneity, we did subgroup analysis for follow-up length, and we based that on a previously published meta-analysis that was seeing significant differences for 1 year. So we use the categories from previous meta-analysis to make it relevant for our data. And for one of them, we were able to reduce statistical significance, which was alcoholic etiology. However, for the others, it did not make a significant reduction in the heterogeneity, but we know that there is a significant clinical heterogeneity in the studies included. Thank you.